pleasure of introducing Dr. Weisbart. He is the National Board Secretary and Missouri Chapter Chair of the Physicians for National Health Program, a nonprofit, nonpartisan organization that supports single-payer national health insurance. Dr. Weisbart is a retired family medicine physician who practiced over 20 years in the Rush Medical Center in Chicago before he moved to St. Louis, where he served as the Chief Medical Officer of Express Scripts. He also, during that time, volunteered as an assistant professor in clinical medicine at the Washington University in St. Louis, and then also served as the president for the Consumer Councils of Missouri. And thank you very much for coming in, and we look forward to our talk on the public option today.
Well, thanks. Thanks for inviting me, and I've been looking forward to this too. So, public option, it's an interesting topic. Let me get my slides going if I can. There we go. It's one of these things that seems to continually come back as a topic for discussion. It's been described as the perennial runner-up. It never quite gains traction, but it's something that is worth understanding, and I'm glad to have a chance to talk about it with you because it's got some merits and it's got some challenges, and there are some ideas that we could discuss about how to maybe leverage things to take advantage of the merits with avoiding the challenges. But I don't even know if that's quite possible, to be honest with you, but maybe. So I want to walk you through the pros and cons and sort of what it is, how we got to it, and stuff like that, and then talk about the status of it today, and frankly, the status of it tomorrow. And I think we'll have quite a bit of time available after I kind of walk through that, because I really want to hear what y'all think. This is not a resolved issue, at least in my head. There's stuff to talk about here, and I am very much interested in being informed by what you all think after I get through kind of laying out the landscape. So to start with, it's, as I said, it's not a very new notion. It was introduced 23 years ago into the healthcare discussion field by this guy, Jacob Hacker, who's still writing in some ways about it. Now, I'll tell you a bit about what he has to say today, but it's a 23-year-old notion, and his initial intent was he began as somebody thinking we should get to universal health care, and he created this notion as a way to kind of bridge what he saw as nearly insurmountable political and administrative barriers to accomplishing universal health care. So it's basically a public insurance pool, as originally described by him. It would be structured very much similar to Medicare, and within a few years, he'd gotten quite a bit of political traction to the point that most of the people running, most of the major Democratic candidates, and of course, as so often in the case in healthcare reform, none of the Republican candidates embraced it, but most of the major Democratic candidates did. So he, it was getting some serious traction in 2008. And as you probably recall, it got built into the Affordable Care Act and then got excised from it. So we'll come back to that. So his perspective on it, most recently that I found 3 years ago, and I'll just read this to you. He said that public insurance through Medicare, in other words, single payer Medicare for all, remains the most realistic way to guarantee universal coverage. So his end vision is the same as what PNHP would say. But he says this, he says that advocates need to lay the groundwork now for universal coverage by both improving Medicare and the ACA, and by establishing the foundations for automatic enrollment for people without alternative coverage. We're going to unpack that a lot. So the most recent that I found from him is still promoting this as an incremental step towards getting to single payer. That's him. On the other side of the coin, in red, is Sally Pipes from Forbes Rating and Forbes Magazine. And even though I believe I disagree with almost everything I've seen her write, Sally Pipes is really smart and really informed, and I disagree with her point of view and her conclusions, but let us not disregard her. She's bright and she's a decent, but she's saying, I think, all the wrong things. So she says Medicare for all and the public option are two paths to the same destination, a government takeover of the health insurance system, the government takeover. She said that at least Medicare for All is honest about that, but that the public option slouches towards single payer. So we're going to unpack a lot of this for you, but there's sort of I think the best sort of descriptions of the two camps broadly. So let's talk about the policy itself, both its merits, because I believe there are some potential, and then the downsides to them. The merits, this is basically the idea of a public health insurance model. So it would be the way they're proposing it be offered to the public in a variety of possible ways, which we'll talk about. And in theory, you could design it completely to be aligned with public health interests. And so it would hopefully be a better choice of health insurance. Structure it to be better and not to be for profit. Have it, so we'll talk about that. The idea being that if it's for sale as a better product, both price and quality, well, then it would be applying the principles of the free market. And if indeed the public option were good, it would thrive, survive, and take over the entire insurance industry. And if it's crummy and not a good value as people perceive it, then it would wither and die. So the free market folks really find that part of this model attractive. If indeed it were thriving and doing a good job and people wanted it, well, then it's a pathway towards universal coverage, which is a goal many of us share. And yet, because it's not imposing a replacement, it's a free market intervention in theory. It wouldn't as radically and abruptly disrupt the insurance industry as a single payer model does, frankly. So that's not a trivial point. When you talk about single payer, you'll hear all sorts of concerns, which I imagine you're hearing about during this entire internship. But one of the concerns you hear is that the insurance industry today, or health insurance today, or healthcare today, is pushing 20% of the GDP, and the insurance industry is a big part of that. And so if you abruptly disrupt the insurance industry, what's that going to do to my stock funds? What's that going to do to my retirement? What's that going to do to the whole economy? So people who align with us on the goal of single payer even are often pretty concerned about that set of issues. And so this would mitigate against that. This would be a market solution that would be gradual and not as abrupt. And for all of those reasons, the idea is that this could be easier to fight for than Medicare for All is. So that's the merit. Easier to get to, applies to free market, so it has broader sort of appeal, and could be designed to be a really terrific system. Okay, what's wrong with that? What's wrong with that is the opposition is very strongly against it. The same adversaries as we have for single payer see all of these arguments and go, well, wait a minute, I don't want you to even a gradual disruption. I want my insurance industry that is where they're employed. So they intentionally are blurring most of the messages about public option as being the same as single payer. And indeed, the ads during the period when this was a prominent political issue typically would say things. If you support the public option or the single payer or Medicare for All, if you support any of those things, you are, this. So the ads overtly were coupling candidates who supported public option as being single payer. In other words, they were intentionally blurring these issues, whereas we know they're different. So another challenge is that the public option would be another choice on the marketplace, right? So instead of dealing with 13 insurance companies in my practice, I would have to deal with 14 insurance models in my practice. More complexity, you wouldn't get the savings of a simplified, streamlined system. You just make it more complex for patients to pick from, more complex for physician practices and hospitals to deal with. So more complexity, not less complexity, at least before it became universal. And that complexity means that you would have a hard time capturing the economies of scale. I mean, how does single payer pay for itself? Two things: economies of scale by using purchasing power, and administrative simplification. Well, you would have neither of those things built in. You would have neither of those things built in. You would have some, which we'll talk about, but you wouldn't get the huge savings that we know the country desperately needs for all sorts of reasons. Another argument against it is that who would go into this? We've got this better insurance product on the public exchanges. So who would choose that? People who were sickest and who weren't getting their health care needs met by their employer's insurance or whatever. So if that were indeed the dynamic, then it would quickly become a high risk pool. And every time we've experimented with high risk pools, they have decayed into spiralingly, is that a spiraling? Well, I don't know what the adverb there is, into an increasingly, there you go, into an increasingly expensive model that becomes harder and harder to justify funds for because most of the people wouldn't be in it. And so if you're talking about ramping up funding for this high risk pool, some would want to do that, but most people would say, well, I'm not in the high risk pool. I don't, and it gets marginalized. So high risk pools often really struggle as a solution. And indeed, they're vulnerable, right? Because then you can look at the cost of they've got this public option, and those people cost this much money, whereas people that are in employer-based insurance cost that much money. So clearly, employer-based insurance does a better job of keeping costs down. This public option just shows the pitfalls of single payer. We should not even see how expensive it is. Very easy to misrepresent the consequences of a high risk pool, which is what some would argue this could turn into. So high risk pools are a bit of a, what did I do? What did I do? You go back. Sorry, that's me not hitting the right keys. So you get to see the whole thing again. Okay, great. Sorry for that. High risk. I don't know what I even hit to do that. Okay. Another problem with the CISA model is that if one of our concerns is that people that have insurance have crummy insurance, if this is just an option and employers aren't compelled to use it, which why would they be? Then the people who are underinsured, who have insurance with these massive deductibles and massive copays and huge financial barriers, underinsurance, which I'm sure you've been hearing about, how does this help them at all? And there's no projection that says that this would really greatly reduce the numbers of uninsured. So is this something we want to, tie our wagon to and start spending our precious advocacy resources on? Well, maybe not. So how do you mitigate some of these challenges? So what I've said to you so far is essentially PNHP's point of view of these challenges and problems, and sure maybe some benefits, but focus there. Now what I'm going to tell you about risk mitigation strategies. This is me talking. This isn't the organization's point of view. So the idea that there are ways to mitigate the risk, just so you know, is me talking, and I don't know that we have very big consensus within PNHP that these are potential strategies. So anyway, potential strategies. Blurred as single payer is an argument. Once it were installed, once it were up and running, that would no longer be the case, because it would be a clear thing that existed. So being blurred as single payer is a transitional issue. The complexity, all of the things I said about the problems with complexity and the lack of simplification, all of that's fundamental to the model. There is no way to mitigate that, I don't think. Few of the savings, well, you could probably capture some of the savings were the program run as a public program. If you could find ways to leverage some of the things that we're doing in public, you should be able to capture some, clearly not all, of the savings. The high risk pool, here's where it gets, I think, interesting. High risk pools are particularly problems in small groups. So if you had a way to turn this into a large group, and I'll show you how you could, if you had a way to turn this into a large group, you could mitigate the risk of this being a high risk pool. Making it available to everyone would help deal with the issue of the underinsured people. So have it available to people who have employer-based insurance, let them opt into it. Let employers opt into it. Then that would help with it. But millions remaining uninsured because they wouldn't opt into it. And this is where there's an important lesson from behavioral economics. So let me sidebar into behavioral economics for just a moment. And that's the difference between opting in and opting out. So employers, when they were benevolent employers who were trying to get their employees to opt into IRAs, investment program or retirement savings programs, would offer a retirement savings program where you could divert 1%, 3%, 6% of your salary into a tax-deferred retirement program that then you couldn't tap until you retired. Very few people adopted it. They tried matching funds. They tried actually, because the ones that wanted to do this for their own reasons, set up a program where you could, if you put in 3% of your salary into the retirement fund, the employer would match that with another 3% that didn't come out of your salary as a bonus into your retirement savings, and up to 6%. So some employers went as high as a 6% match that you would defer on your income. With all that, with your employer encouraging you, with that match, with 6% match, a bonus, with all that, about 15% of people who were offered this program with a match, about 15% chose to do it. 15%. If you had to opt in, nobody does that. So the change has been within the people who wanted to do this program, do deferred savings by this program for their employees, has been to make it an opt-out program. Opt-out. So you're automatically given, let's say, 5% of your salary is automatically deferred into your retirement program, and your employer automatically matches 5% more on top of that. That shifted it. You can get out. You don't like that, you can quit it. You can get out anytime. You can decline it right at the beginning, or anytime you want to opt out, you can opt out. And that shifted from 15% adoption to 85% adoption. Going from opt-in to opt-out shifted retirement programs from 15% to 85% adoption. It's hugely powerful. Why is that? Well, because who spends the time thinking about this stuff? Somebody in HR told you when you signed on. You just, okay, that's what we do here. You don't think about it. You don't see it. It's invisible. There is this, it's a match. There's all these reasons. So you leave it alone. It's inertia. And yet, it's good to be able to opt out of things. We like that. So, okay, so opting out, an opt-out program in general terms has much broader adoption than an opt-in program. So if our goal is to get people, is to make this a large program so that we can mitigate the risks of adverse selection, one strategy towards that is to make it an opt-out. So that means automatically enroll everybody who doesn't have proof of insurance, automatically enroll everybody in the public option who doesn't have proof of insurance. And then you'll hear the stuff you heard about the ACA. You can't make me have insurance, can't do that. So, okay, fine, make it an opt-out. You don't want this free, health insurance benefit. Nobody's making you opt out. So if you wanted to make this grow the most dramatically, you would make it opt out rather than opt in amongst the uninsured. Okay, so let's look at what are the characteristics of a best case public option. And here, Jacob Hacker, whom I mentioned before, has done a lot of the work. And then there's some other stuff referenced on my footnotes too. But the first most important principle of making a good public option is to have it strongly tied to Medicare. So have it traditional Medicare, not have it be part of Medicare Advantage for all the reasons that I'm sure you know about. So have it be strongly tied to Medicare, a true public program, not a commercial version of that. And that means that you could then use the traditional Medicare national networks. So if you're in the public option, you could go to nearly any doctor and hospital in the country. That's one of the reasons not to tie it to Medicare Advantage or even to Medicaid, because those are state-based programs, and so strongly tied to Medicare, and require those physicians who accept Medicare, require them to also accept the public option patients. And public option would be strongly tied so that the reimbursement rates to physicians would be identical to the reimbursement rates of physicians taking traditional Medicare. So if as long as the payment were the same, it seems not unreasonable to say if you want to take Medicare, doctor, you also have to take the the public option program. So that would probably ensure that you would have the same broad network of traditional Medicare physicians and hospitals available to people in the public option. So this would also make it national, not state-based, like I alluded to for Medicaid. So strongly tied to Medicare, traditional Medicare, is a key component in my mind of making a good public option. A second good thing to make a good public option is why just Medicare? Make it better than Medicare. So a good public option that's competing with commercial insurance has to offer all these other things, right? Because we're not talking about the 70-year-olds at this point. We're talking about the uninsured people who aren't eligible for Medicare because they're too young and haven't diseased into it. We're talking about younger folks who are looking or shopping for insurance that includes these other benefits. So expand the benefits. A good public option to thrive would have to be better than Medicare in all of these ways. It could also be designed to be better than Medicare by not having copays and deductibles, and therefore you wouldn't have to deal with Medigap for your public option. I mean, that would be really a complicated nightmare. Go to the public option and shop for Medigap. I mean, what a nightmare that would be. So eliminate the copays and deductibles. And then, of course, it would be an option. So there would be a premium for it. You'd have to pay for it and still give premium subsidies for low income folks, much like the ACA does in the rest of the system. And then, like I said, it needs to start big and grow. So in addition to what I said before, you have to let any individual opt into it. You have to let any employer divert their employer-based insurance. I'm sick and tired of having my HR meetings where we talk about which health insurance I want to offer to my employee. Every 2 years, I got to divert HR time on that. I'm sick of that. We're just going to start offering we'll pay the premium for your public option. So let employers make that decision. That would, again, get you a big waft of not adversely selected employees. And let states say, hey, we're sick and tired of trying to sort through how we're going to run our Medicaid plan. Let states switch from offering a statewide Medicaid program into paying the fair share of what it would cost to put all of the Medicaid patients into the public option. Again, starting big and growing to avoid adverse selection consequences. And then, as I spoke to before, auto-enrolling everybody who's uninsured and letting anybody easily opt out. So that's what I mean by these are the characteristics that I think would define a good or a better public option that would mitigate many of the concerns that we have. It doesn't mitigate all of them by any means, but it would mitigate some of them. So it's really important. I'm so glad Marvin invited me to talk about this. It's really important because this was a hot topic a few years ago. And I predict no matter who wins the general election, it's going to be a hot topic again in 2025. So when it does come back up as a hot topic, it's good, I think, to have a framework in your head of what are better and worse characteristics. And that's going to be the exercise at the end, is try to think through what y'all think what y'all think about what I'm saying. So politics have been shifting quite a bit. Just in 2019, there were many public options that were in Congress. These are active bills in 2019 in Congress. So there were some that said for older adults, people 50 to 65, let them buy into Medicare. That's one form of a public option, targeting older adults starting at age 50 to buy into it. And there's a couple of bills that were active in 2019 about that. In 2019, there was the State Public Option Act that was opening up Medicaid to anybody who wanted, any state that wanted to offer it. And then there was a set of things that were public programs that you could opt out of, much like I described. That was called the Medicare for America Act. And then public plan options, a range of them. So part of the reason I'm really glad to be talking about this right now is that I was talking about this in 2019 and had to unpack every stinking one of these. It was a nightmare because the people that were running for president had different preferences, and it was a nightmare. That's not the case. Today, there are only three. These three are active in Congress in 2024. So I'm going to do a high-level discussion of two of them, and then the last one, the Medicare X Choice Act. I want to, I left off the word act there, there's act on it too. I want to unpack that one just a little bit, actually quite a bit more. So the first one is specific. Why can't I see that? hang on for a second. There we go. Okay, the Medicare Buy-in and Healthcare Stabilization Act, that's in the House today. It would do some of what we talked about. It would let people buy into it and understand if you're buying into it, and that's all that there is going on. It's budget neutral, right? And that's so that makes it that gets it past one of the barriers to adoption. And it would basically be putting this public option on the Affordable Care Act exchanges, which would mean that people could, do comparative shopping. They believe that because they could be their unit costs would be low because they could leverage Medicare contracts, and because they would be much more administratively simple than commercial insurance. Their projections are that an annual premiums on the marketplace would be a fraction, 2/3 roughly, of what the best plans are cost in the ACA. So attractive in that sense. They do say that they should be eligible for the premium tax cuts or cost sharing reductions that people currently have. That those current cost sharing reductions could be applied directly over to the premiums that people would have to pay on the marketplace. So that's an expense, but it's a budget neutral expense because it's things that are currently being available. And they say that employers could opt in or contribute the premium, contribute a fraction or all, whatever they chose of the premium for their employees who were choosing to opt into this instead of taking the employer-based insurance. I don't believe it has room for the employer to ad hoc move the entire book of business over to it. But of course, if all of their all their employees chose to do it, then that would be the same thing, and then employers could contribute to it. So that's the first of the three bills that's still active. The second is the State Public Option Act of 2024. That's in both. It's bicameral today, marginally bicameral, 2 in the House, 1 in the Senate, but it is bicameral today. And this is pretty straightforward. It says that a state that wanted to could open its Medicaid program to anybody and not have to apply the income restrictions that it has. And as you know, income restrictions today are very widely by state. In my state, you have to be like completely destitute. In some states, it's fairly reasonable. So, but this would eliminate that. A state that wanted to go further and eliminate any income barriers to being enrolled could do that and enroll anybody into Medicaid. Oh, I should never have changed my computer. There we go. Never Medicaid. Okay, so there are 3 states that are anticipating this as becoming a policy and are actually currently exploring whether they would want to go into it. Another one I want to spend a little more time unpacking instead of comparing to criteria is this one, the Medicare X Choice Act, because Democrats really know how to name things. Medicare X Choice Act. Really? Okay. That is what they named it this some years ago, and they have stuck to it. So I can't explain why. So the 3 criteria that I want to judge it against as a model for what I want y'all to be thinking about is, first, is it strongly tied to Medicare? Second, is it better than Medicare? And thirdly, does it start big and grow? So if you wanted to pick, those are the 3 criteria that I spelled out and unpacked a few minutes ago. So is it strongly tied to Medicare? It's a publicly administered plan sold on the marketplaces that's allowed to use Medicare contracts, or if it doesn't want to, they could contract with other entities. So pretty strongly. And it would say that if you're in Medicare, if you're a physician or a clinician or a hospital in Medicare or Medicaid, that you would have to accept Medicare X patients at the rates that are in traditional Medicare. So pretty strongly tied to Medicare. A separate insurance product, not Medicare, but pretty strongly tied to it. Better than Medicare, it would cover all of the essential benefits of qualified health plans, which is largely the Medicare benefit design. Plus, it would eliminate copays for any primary care visits. So maybe better. It would further direct Medicare to study what other benefits should be added. So maybe a pathway towards broader benefit design. It would there would be a premium. It's an option. It's a Medicare or public option. So there'd be a premium, you'd have to pay for it, but the premiums would be limited to 8.5% of your household income, and probably less than that in many cases. The design has four actuarial levels, gold, silver, bronze, platinum, much like the ACA does. Okay, that's not better than Medicare. That's a complicated, piece. That's a nightmare to try to navigate. Well, how sick do I want to be next year? Oh, not sick at all. Well, too bad. It's not what you picked. So four levels, then not better than Medicare. And it applies all of the things that I think are egregious and don't have value. It still leaves room for ACOs and ACO Reach today, and leaves rooms for all of the kinds of programs that drive most physicians just like crazy. So better than Medicare on that one. I'd say it's just as bad as some of the problems with Medicare today. Start big? No, it doesn't start big. It would start in areas in geographies where healthcare costs are high, and it would have fewer choices, and it would then expand to areas that have zero or one insurance choices. So if you're in an area where there's no insurance option in the ACA, or where there's one insurance choice on the ACA, it would expand. It wouldn't start with that, but it would expand into that. And it would also expand into areas where there are shortages of providers. So not starting that big. It would be offered to individuals and small businesses, opt in, not opt out. No auto enrolling, no transfer of Medicaid. Medicaid wouldn't be able to go into it. No employer shifting their whole book of business. So I think it'd be pretty vulnerable to the issues of adverse selection. They haven't developed stuff that would make it mitigate the risks of adverse selection. So it's a difficult strategy. It's a heavy lift. The opposition, the adversaries are the same. And as you recall, the adversaries against this nearly prevented the passage of the Affordable Care Act. If you recall, when the ACA was first written, up until like the day before it was enacted or passed, not really the day before, but up until right before that, a week or two before that, the ACA included a public option, and it was not going to be enacted. Joe Lieberman from Connecticut was, the Democrats had 60 votes if they were lucky, and Lieberman was number 60, and he very clearly said, if that's in there, I'm not voting for it. So it would have failed. It would have failed. The ACA would have failed, and that was why the Democratic Party removed the public option from the Affordable Care Act. So the ACA wouldn't have passed. Opposition to the public option is strong. And we target Joe Lieberman as the person who did that. And he passed away a few months ago, and that's sadly become one of his claims to fame, is that he's the person that killed the public option out of the ACA. But it wasn't Joe Lieberman as one person; it was the entire insurance industry that compelled him to vote in that way. So, at any rate, the message is the ACA wouldn't have passed if the public option were still in it. Strong opposition. And the public option has all of the same adversaries as were involved in constraining the ACA, as well as all of the adversaries that don't like Medicare for all. And perhaps just as importantly is the issue that how long would it take? Hacker described it in 2001. In 2008, it was above the fold in the newspapers. And it's a lot of the bills died off. There's still some bills. If we decided we wanted to fight for the public option, there would be more years, 2, 3, 5 years of working to get it to be passed. There would be years of advocacy on that wouldn't be going towards single payer. And then, these bills don't go live immediately. It's 2 to 5 years for one of these bills to go live. So let's say 4 years to advocate for it, 4 years for it to go live. And then once it's live, people are like, don't talk to me about healthcare. I am sick of healthcare. And so, it would take, let's say, 4 more years for there to be experience to actually analyze it. Nobody would want to talk about anything to do with healthcare for that period of time. And then the analysis would show all the things I talked about. It would show potentially adverse selection and high risk pool, and it would show that it didn't have the impact that we wanted, so we're looking at 10, 15 years of consuming healthcare advocacy landscape and still having to go to single payer at the end of that. So, I mean, I'm 70. Please don't make me be 85 before we get to that point. So politics in 2020, the Democratic Party platform had this quote. It said, low-income Americans would be automatically enrolled in the public option at zero cost to them, although they could opt out at any time. Low-income Americans. So, I mean, that's not exactly what we talked about, but that's what the Democratic Party platform said. Oh, shoot, I did this backwards. Sorry, didn't update. President, I'm going to go into the middle in a moment, but President Biden in the last 4 years has not even said the phrase public option. I was interested in something that during the debate, he said something about we're going to get, no, right after the debate, I think it was, he said, we're going to get universal health care or health care for everybody. He didn't unpack what he means by that. And he didn't say the phrase public option, but in the last 4 years, he has not said the phrase public option. But when he was a candidate, oh, I really built that badly. Sorry. When he was a candidate, he specifically ran on publicly run plans that could use Medicare rates that would be available to anybody. Um, and but it would also, the program he ran on was predicted to have higher out-of-pocket costs than most employer plans. So the politics are complicated and shifting. I thought it was pretty interesting that when he said last week that he supports universal health care without saying exactly what he means about how to get to it. But he has supported some things in the past, clearly not single payer. He supported some things in the past. So the reason I think this is so timely is that I predict to you, regardless of who is elected next year, later this year, we're going to see a variety of public option proposals reemerge out of the scene. Some will be better, some will be close to the ideal that I've described, and I would like to hear from you if you think that ideal would be something worth fighting for or not. I don't know. I'm not sure. I certainly haven't diverted to it, but I want to hear what you think about that. So the question is, which, if any of these, would you support?